Hey guys, okay, so this video is going to be all about everything perioperative that you wanted to know, but were afraid to ask. So I'm going to share my screen with you and we will get started. So what are we going to learn? We are going to learn the factors that influence surgical outcomes, right? So things that can have a positive or negative impact on how a patient does with surgery. We're going to identify the nursing role in every perioperative phase. And remember, peri means kind of around or all through. So perioperative means pre-op, intraoperative, and postoperative. Before the surgery, during the surgery, after the surgery. We're going to talk about nursing roles with informed consent. And we're going to talk about teaching plans to help enhance learning, especially for older patients, right? Which is important. So we're also going to talk about nursing interventions that are used for common, typical post-op patient needs. So what kinds of things must we concentrate on for post-op needs, like prevention of DVTs, prevention of post-operative pneumonia? How do we evaluate the effectiveness of those nursing interventions? Signs and symptoms that we need to be looking out for when we talk about common post-op complications like the DVTs and the post-op pneumonia. What are the criteria for ambulatory discharge? In other words, what are we assessing that tells us, yeah, you can leave? What is the role of home health care nursing with post-op patients? So when we do a surgical procedure, do we send the patient directly home with home care? Or maybe if there's not a support system, we send them to a rehab facility. We'll talk about the different reasons, right? So let's talk about surgery urgency levels. Make sure you understand the word emergency. Emergency means life or death, right? So an emergency surgery means if I don't do this procedure on you, you could die, right? That's important. So if a patient comes into the emergency room, they need a procedure, I don't need consent forms signed. You know, I can't tell the patient, listen, just like stop bleeding right now, and I have to just try to get a hold of your power of attorney. No, the consent rather is implied, right? So that's emergency. It's life or death. If I don't do it now, you could die. Then we have urgent. Urgent is a procedure that needs to be done in the next day to 3 days, 24 to 72 hours. We need consent. It's not life or death, but you need it. The patient must have this surgery or bad things will occur. There will be bad consequences. So it's urgent, but it's not life or death right now, not an emergency. Then we have elective surgery. Elective surgery means it's not required, but it's highly recommended. You have really bad osteoarthritis in your knee and you really would benefit from having a knee arthroplasty done. You know, it's that. And then optional. With an optional procedure, the patient's health is not at stake, right? A good example of that would be cosmetic surgery. You don't need your boobs lifted, but you want them lifted, right? So that's what that's about. So when we talk about the purposes of surgery, we do surgical procedures for lots of different reasons. The word aesthetic means pleasing to the eye, something that's nice to look at. So aesthetic surgery is things like cosmetic surgical procedures, a rhinoplasty, a nose job, a breast lift, a tummy tuck, a tush lift, right? All of those things, you don't need them, but you want them. You want them because you think it's going to make you look more pleasing either to yourself or to other people. It's aesthetic. Diagnostic procedures. A diagnostic procedure means we believe that there's something happening. There's a disease. For example, we believe that this is cancer, but in order for us to definitively diagnose it, we need to actually go inside and find evidence that it is cancer, right? So say with a biopsy. Okay, that's diagnostic. The surgery is not to cure you or fix something. We're doing the surgical procedure because we need to diagnose you. Then we have something that's called exploratory surgery. Oops, my bad, okay? Exploratory surgery is just like the name implies. We're looking. We are really not sure maybe what's going on with the patient. We have a couple ideas based on symptoms of what may be happening, but we're just going to go in and we're going to take a look around. It's not the same as diagnostic. With diagnostic, we found something, but we need to be sure that it's what we think it is. With exploratory, we don't know, but we're going to go in and take a look. Okay. Preventative surgery is, and I use Angelina Jolie as the example for this. There are genetic blood tests that we can do that will determine what kind of a risk we are for things like breast cancer, ovarian cancer, right? And so Angelina Jolie had this blood work done, and it found that she was a very, very, very high risk for both breast cancer and ovarian cancer. And so she said, well, I don't want breast cancer and I don't want ovarian cancer, so just get rid of them. So that preventative surgery was, they removed her breasts. So she had a bilateral mastectomy and she had a hysterectomy, and they removed her ovaries along with her fallopian tubes and her uterus, right? That was preventative. We want to make sure that we don't get cancer, right? Then we have curative. Curative is, we found a tumor in the right middle lobe of your lung, and we know that it's cancer. However, we can go in and we can excise, remove that tumor and cure you. And then you won't have cancer, hopefully, anymore. That's curative. Reconstructive, just like the name implies. Angelina Jolie, go back to the preventative. So she had a bilateral mastectomy, both breasts removed. Then she went in and got 20-year-old boobs. That was reconstructive. So they gave her a new set of boobies. They reconstructed and gave her new breasts. That's reconstructive surgery. Reconstructive surgery can also be, you were in an accident and there, a part of your face was disfigured or something like that. We can go in and reconstruct it to try to make you, back to the way you were before. Reconstruct. And then last but not least, the word palliative basically means not curative, but we want to make you comfortable. Palliation of symptoms means relief of the symptoms. Palliative surgery is where we're going in to maybe remove all or part of something like a tumor. We can't fix you, but it's going to relieve some of your pain and discomfort. So it's not curative. They can sometimes go in and do what's called a debulking. So if the patient has a very large cancerous tumor, part of it is impinging on nerves and causing them to have a lot of pain, we may be able to go in and take part of the tumor, debulk the tumor, remove part of the tumor surgically to provide comfort and pain relief. But it's not meant as a cure. It's not going to be cured. Then we have types of surgery. We can have open procedures. Whenever you hear open, like an open chole or a total abdominal hysterectomy, open means we cut you open, right? Just like the name implies. It means that we bring you into the surgical suite, and with an incision using a scalpel or some type of sharp instrument, we are cutting you open to go in and do that surgery. It's whatever the surgery happens to be. It's an open approach. Then we have other approaches that are considered less invasive or minimally invasive. So we're not cutting you open, but we're getting inside in a different way. Examples would be an endoscopic surgical procedure. There are things called keyhole procedures that are done to do valve replacements in the heart. There's also now something called a TAVR, which is for aortic valve replacement or repair. And that we're not cutting you open. We're making something that more looks like the name implies, kind of like a keyhole in the anterior chest. So it's not a big open incision. Then we can use a scope, laparoscopic, thoracoscopic. So we can use a scope, say if you need your gallbladder removed. Well, we can do a cholecystectomy laparoscopically, where we make puncture wounds, one at the umbilicus, and then usually 3 more strategically placed in the abdomen, to go in with a scope, which is a camera, kind of in a tube, so the surgeon can be looking on a screen inside of you, while those other puncture wounds allow for a surgical implement like a scalpel or forceps, hemostats, and those types of things in there. So they go in just through these little puncture wounds and don't have to make an open incision. And now we have things like the Da Vinci, which is a robotic type of surgical procedure, less invasive. And then there are laser surgical procedures. All of those, when you compare them to open procedures, because they're less invasive, they usually have a quicker healing time. And there are fewer potential complications associated with those. That's kind of just a picture of a robotic surgical suite. So the surgeon sits in a chair and is actually, they put their hands inside these robot-like hands. So the surgeon controls the robot, but the robot's the one doing the surgery, right? With this under the surgeon's control. That's the Da Vinci surgical system. It's wild. All right, let's talk about the perioperative phases. We have the pre-op phase. That's where you make the decision to do surgery, and that carries on through the transfer to surgery. Now you're in the surgical suite. We are in the intraoperative phase. That means that's where the surgery is happening, right? Until you leave the surgical suite and go to PACU. And PACU is the post-anesthesia care unit. That's what PACU stands for. And back when I worked in the hospital, we used to make fun of them and, oh, you shake them and wake them all day, because PACU is basically the recovery unit, right? Post-anesthesia or peri-anesthesia care unit. That's where we make sure that the patient is awake, that the anesthesia has worn off, and that they're stable enough to go on and either go and be admitted onto a medical surgical floor, or maybe they need to go home, right? But that's where they get stabilized after surgery. So what's the nurse's job? What do you have to do? So preoperatively, you're going to help with data collection. You're going to help to reinforce instructions. You're not responsible for explaining to the patient what they're going to have done. That's the doctor's or the surgeon's job. But you will reinforce those instructions. You will provide emotional support, psychological support. You'll help gather the data that's needed for things like the pre-op checklist, which we're going to look at next. And you also help provide family care, comforting the family, answering questions possibly, or possibly referring questions on to the surgeon, depending on the level of questions. When we talk about factors that influence surgical outcomes, understand, if you've ever heard somebody say, oh, she's not a surgical candidate, what does that mean? That means that the risk of surgery is greater than whatever benefit it could possibly do. And so people that have things like chronic diseases, like diabetes mellitus is a very, very huge factor, negative factor, in making decisions about surgery. Because with diabetes mellitus, more so if it's been uncontrolled or erratic, patients will typically have a very difficult time with healing and a prolonged healing process. So the longer it takes for the surgical site to close, the higher the risk for infection becomes. So that's chronic disease that would be a huge factor in influencing the surgical outcome. Age, again, I say this all the time, who's fragile? The very old and the very young, right? They tend to be more fragile and a higher risk. Emotional responses or emotional states. Your psyche or your psychological state of mind and your emotions can have a huge impact on how well you recover. So if you're going into this surgery with the mindset like, I'm going to have this done and I'm going to do great, that's a much better potential outcome just based on your mindset than the patient who's going, I don't know if I want to do this and I'm going to do this and I'm probably going to be in a lot of pain afterwards and this is going to be horrible and it's going to suck. They already have that negative mindset. And believe it or not, that can have a big influence on how well they do postoperatively. Their nutritional state. Again, you're looking at extremes, right? Somebody who is obese, and obesity, we're talking about, a BMI of greater than 30 or 31, or somebody who is malnourished. And that's usually a BMI of less than about 17, okay? They're both high risk patients, somebody who's very heavy or very thin, malnourished, right? It's going to have an impact on how well they are able to heal. And, things like, when we talk about obesity will have an impact on the ability to move quickly after the surgical procedure, because early ambulation, we know, is a must in the prevention of things like DVTs, post-op pneumonia. Obesity has an impact on the healing process, because we usually have to be more invasive surgically to get to whatever it is we're operating on, which means more invasive the procedure, the lengthier the time to heal, right? And then on the other side of the coin, people who are malnourished, in order to heal, you need to have an adequate amount of protein, an adequate amount of B vitamins and zinc and all the other nutrients that are necessary. People that are malnourished typically have lower or sub-therapeutic levels, and that makes it very difficult for them to heal after the procedure and recover. Smoking, not for me, but other people. Alcohol and drug abuse are things that absolutely have a factor that influences surgical outcomes. Smoking actually is proven to constrict blood vessels. And so for people that are smokers, we will always tell them to please refrain from smoking at least 24 hours before the surgery. And if they have a lung disorder of any kind, if they have COPD or anything like that, 3 to 4 weeks. I mean, they probably shouldn't be smoking, but then again, the damage done, But at any rate, smoking constricts blood vessels. And if there's not adequate oxygenated blood flow, the healing process is diminished. Okay. So those are all things to consider when we're talking about who would benefit from surgery versus who would be a high risk. Okay. The emotional responses. I mean, people become afraid. Fear is a normal human emotion. We all are fearful at some point. What are they afraid of? Well, there's fear of dying. People are afraid of anesthesia for various reasons. They may have seen a movie or heard something that someone told them about somebody else that something happened to. Like they're going to be under anesthesia and then suddenly they're going to be awake, but they can't move, but they can feel everything and see everything. Accidental awareness under general anesthesia, which, by the way, doesn't be a common thing. People are afraid that they will be brain damaged because of the anesthesia. They'll be afraid that they'll have a total loss of control. Am I going to have a problem with my urine, my bowels? Or that they won't even wake up after surgery. Okay, so these are all, kind of valid fears that people have. People are afraid of pain. Oh my God, is this going to hurt? Or afterwards, when I wake up, am I going to be in horrible pain? And body image. Body image, it's a NANDA nursing diagnosis. I mean, there are a couple of them that have to do with, compromise in body image, altered body image. It's a big deal. Am I going to have a scar? Is the scar going to be noticeable? Are people going to look at it and think the worst? The day that you learn to not worry about what other people think is the happiest day of your life. Promise. Anyway, but these are things that we need to address with patients. So if you have a patient that is anxious and riddled with anxiety and they're getting ready to go into surgery, before you can do anything, you have to figure out what's making them anxious, right? And remember, therapeutic communication dictates never start a question with the word why, because you make people feel some type of way. Why do you feel this way? No, it would be better to say, can we talk about what fears you have? And maybe we can talk our way through them. Tell me about what you're thinking. It's a better way to communicate. So what are you going to do as far as interventions? Assist the patient with coping. I mean, discussion, always find out what is it they're afraid of, because you can't talk to them about anything until you figure out what the problem actually is. There are relaxation techniques, music, guided imagery, right? And guided imagery is when, what's your favorite place in the whole world? For me, it's the beach. So, close your eyes and I want you to picture yourself on the beach. You can feel the sun beating down on you and you can feel the sand between your toes. And all you can hear is the waves coming in. So that's guided imagery. That kind of helps with people to relax them and get them in a better state of mind. And it actually can work. Okay. it's sometimes the anxiety is so great that there will be a pre-op medication, like a friendly little alprazolam or diazepam. Those are benzos, Xanax or Valium, to take the edge off, right? Sometimes that's appropriate for people that are very, very anxious. If they're very, very anxious and, like if they're going, I don't want to go, that's something that you need to talk to the surgeon about and report that to the doctor, to the surgeon. You always want to encourage a discussion between the patient and the person that's doing the anesthesia. And they will come in and meet with the patient. Okay, that's important so they can help quell some of the fears. Some patients are so afraid to go to sleep, general anesthesia, that they will say, I just want a local. I want to be awake. And sometimes that's appropriate and sometimes it's not. So that, certainly depends on the type of surgical procedure that's being done. But you will hear people that their biggest fear is not waking up. I don't want to go to sleep. So again, but that's something that needs to be worked out through the patient and the anesthesiologist and the surgeon. Okay. So pre-admission assessment, what must you do? You have to get a health history. You have to gather all the data that includes things like risk factors. You're going to be educating the patient, not so much about the procedure, but what's going to happen to them when they wake up, right? Human beings fear the unknown. And so if we give information, usually that will help quell some fears. So when you wake up, you're going to be in a place called PACU. And those nurses, all they do is they make sure that your anesthesia has worn off and that you're awake. And, at that point, you may be able to take some ice chips or some sips of water, as long as the gag reflex is intact again, because patients that have general anesthesia will have an endotracheal tube down their throat. And we want to make sure that after that is removed, that the gag reflex is intact before we give them ice chips or sips of water. Okay. We're going to talk to them about things like you're going to have sequential compression devices on your feet or on your legs to help prevent DVTs. We're going to give you this little toy called an incentive spirometer. You're going to take a deep breath and you can watch that little thing inside rise. And that's going to help you prevent postoperative complications like pneumonia, right? So you're going to give them all this information. Are they going to remember all of it? No, promise they won't. But at least you're giving them information about what they're going to be expecting once they come out of surgery, right? You're going to help with discharge planning. So in other words, like I said earlier, is this a patient that is coming in for a procedure? They're going to have the procedure, and then once they get out of PACU, they're going to go home? Or are they going to be admitted? Or do they need home health care if they're going home? Or they can't go home because there's no support system. We need to send them to a rehab. You will help with these things. And in concert with social services and that type of thing, right? And then diagnostic testing that needs to be done pre-surgery. Things like if it's a female, is she pregnant? We have to have a negative pregnancy test before we can give you anesthesia. Some people need cardiac clearance because they have underlying cardiac conditions. So they'll need to go see a cardiologist and maybe need an EKG or additional lab work done prior to being able to have surgery. And then the other thing, do they have advanced directives or a DNR? Advanced directives is an umbrella term that covers two things. It covers the living will, which is a document that in writing specifies in the event that there's an issue that's an end of life or terminal issue, or could be, do you want things like mechanical ventilation? You want to be put on a vent. Do you want artificial feeding? You want a tube to give you feeding, right? That's the living will. And then the medical surrogate is the other part of it. Medical surrogate, also known as healthcare surrogate, also known as durable medical power of attorney. All those things are synonymous with you pick somebody to be your voice if you can't speak for yourself. Right? You're naming someone. Like if I can't speak for myself, I want my child to be the spokesperson because they know what I want and what I don't want. And it's important for people to have had these conversations. And I know they're, for some people, they're hard conversations, but dying is part of living. And it's something that we do have to become more comfortable talking about. Then we have DNR. DNR is do not resuscitate. That requires a physician's order. And that is where the patient is saying, and the physician is agreeing, if my heart stops beating or I stop breathing or both, do nothing. Do nothing. Do not resuscitate. Okay. So all these things have to be determined. And know this, advanced directives, DNRs, they can be revoked up until the very last nanosecond. So you are wheeling Mrs. Jones into the operating room and she looks up at you and says, you know how I said I don't want mechanical ventilation, I want everything you got. That she is entitled to change her mind. And you will see that people do that a lot, you know. So understand that any of these things, advanced directives or even a DNR, can be revoked by that client up to the very last minute. It's their right. Okay. Preoperative routines, you know, what is the date and time of surgery? Are you getting admitted? What time are you getting admitted? Are you going to be staying if you're admitted? How long are you going to be staying? What should you wear? What should you bring? Don't bring money. Don't bring your wallet. Don't bring your credit cards. Don't bring jewelry, right? All those things are no-nos because in hospitals, sometimes things get lost. So it's important that the patient knows, you know, what kind of clothing they should be wearing. If it's a female, you know, we tell them all the time, like, don't wear nail polish because we're going to put a pulse ox on your finger. And they usually just ignore us and wear nail polish. And, you know, there's always little nail polish remover pads that we have to remove the nail polish so we can put the pulse ox on their finger and get an accurate read. What's recovery going to look like after surgery, right? What kinds of information does the family / caregiver need to have, right? And if the patient is getting discharged, what are the criteria that we're using to determine, yes, patient's ready to go home, and who is going to be driving them because they're not driving themselves? So who is the responsible adult that's going to be claiming that patient at the time of discharge, right? Preoperative instructions, you know, a lot of times there are preps that are done, cultures, right? There could be cultures, blood work, those kinds of things, medications. Sometimes at the last minute, the patient will say, oh my God, I forgot to tell you, but I take 10 milligrams of prednisone every day, but I didn't take it this morning. What do you do? Time's up. So prednisone is a corticosteroid. And I say this because, believe it or not, this is something that does happen frequently. And this is a board question, by the way. So you can't just suddenly stop corticosteroids, right? So if this patient's been taking this 10 milligrams every day for, 6 months, they can't just not take them. So now you're going to have to call the doctor, tell them, okay? That's a big deal because stopping abruptly a corticosteroid can cause something called an adrenal crisis. And we'll get into another lecture. Are they NPO? If a patient is having general anesthesia, they are going to be NPO, nothing by mouth. But how long? Is it 10 hours, 12 hours, 6 hours, 8 hours, right? And have they indeed been NPO? What are we going to do about their pain, right? Are they going to have a PCA pump postoperatively? Or, what there are many, many questions that need to be answered, right? As far as how we're going to manage postoperative pain. And then what kinds of things are we going to be having the patient do along with our interventions to try to prevent those postoperative complications? The two biggest complications are postoperative pneumonia and DVT, deep vein thrombosis, right? And both of those things are from immobility. So I will tell you this, early ambulation, early ambulation, early ambulation. Almost every surgical procedure, even open heart surgery, patient has a cabbage. I am going to go in there and tell them, we're going to take a walk, Mr. Jones. And Mr. Jones will be looking at me like I'm insane. I just had open heart surgery. Yep, come on, let's get you up. And the reason being is that early ambulation is really one of the key ways to prevent both postoperative pneumonia and postoperative DVT. Okay. But in addition, we have teaching the patient to deep breathe and cough. And if there is an incisional site, how to splint the incision. What does that mean? That means If they're going to be deep breathing and coughing, number one, they may be afraid to do it because they think it's going to hurt. Number two, they're afraid they're going to blow out their incision. That's called dehiscence, for an incision to open up after it's been surgically closed. And so you will see patients that, they'll be terrified. You want to manage their pain and you want to teach them how to splint the incision. And all that consists of is taking either a small pillow. Back in the day, we would take a towel and roll it up and wrap it up with medical tape. And that would create something for which they could use to hold the incision tight, and then, right? And it'll hold everything in place, right? Incentive spirometer use. And an incentive spirometer, incentive is that it's tangible. They can hold it, they can look at it, they can feel it, and they can watch the little thing go up, right? So they put the mouthpiece, take a deep breath in, and when they do, they watch that little piece inside rise. And then the incentive is, you got to 1,500, can you get to 2,000? They should be using their incentive spirometer 10 times an hour postoperatively. And I used to tell my patients, this is the easiest way, because they're usually initially in the bed, lying in the bed. See the television? Every time a commercial comes on, use your incentive spirometer. And that's usually minimally 8 or 9 times an hour, right? And then sometimes we'll have them do leg exercises. Sometimes we'll put sequential compression devices on, which are plastic wraps, one around each lower extremity. Each of them has a hose attached to a pump. The pump literally will pump and blow up those vinyl wraps, so it will compress the lower extremity, and then it will let the air out and relax. So it squeezes the leg and then lets the leg go. Squeezes the leg and then lets the leg go. What it's doing, it's mimicking ambulation, because deoxygenated blood gets back up to the heart when you walk and move. Muscular movement pushes the blood back up to the heart. And so if you're not walking, sequential compression devices actually kind of take the place of it. They squeeze the leg and let go, squeeze the leg and let go, and help push the blood back up. Because remember this one line, when blood sits, blood clots. Blood needs to keep moving. And by the way, everything in your body is all moving constantly, and it's all South Philly. It's a one-way street, right? There should never be a backflow of anything, and nothing, especially blood, should ever be still. Keep it moving, okay? There's a lady using the incentive spirometer. See, that's what one looks like. Look at that nice nurse. She looks happy. Preoperative patient assessment. Like I said, you need their health history. You want to know every single thing that they put in their mouth. Everything. Any herbs, any supplements, over the counters, prescription meds, everything. And then, of course, a head to toe assessment needs to be done. Here's some pre-op nursing diagnoses: anxiety, fear, blah, 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 right? Deficient knowledge. Consent. This is something that gives people trouble sometimes. The patient must give legal and written permission for surgery. This is informed consent. That means that the surgeon, not you, the surgeon has to explain, what are we doing? What kind of procedure are we doing? Why are we doing it? Are there alternatives to the procedure? In other words, could we manage this situation medically with medication, or must you have the surgery? What are the complications of the surgery? What are potential consequences? What could happen, up to and including the D word, death? Right? That is the surgeon's responsibility, to explain all of that. Okay? The patient cannot be sedated. They cannot have had any type of medication that would alter their cognition, right? And of course, it needs to be voluntary. They can't have, somebody behind them going, sign it, sign the consent, sign it. It's got to be of their own free will. And they can withdraw consent at any time, but an informed consent is typically valid for 30 days. You are witnessing. So what is your job? You are just witnessing the fact that the patient has been informed, You can't really answer questions about the procedure because you're not the one doing it. The surgeon has to do that. But your signature as a witness means that you observed the patient voluntarily and of free will and with no cognitive impairment that they signed. Okay? That's what you were witnessing. You were witnessing that it was voluntary and that there was no impingement of cognition. So the patient was awake, alert, and oriented when they signed. That's it. Right? That's your responsibility when you sign as a witness. Right? If they have questions about the procedure specifically, just a minute, Mrs. Jones, let me call Dr. Johnson. Those questions have to go to the surgeon. Okay? And then prep for surgery. There is a pre-op checklist, okay? And then pre-op medication, sometimes a prophylactic antibiotic. A doctor will order some IV antibiotic before the surgical procedure to prevent a potential infection. ANSEF is a popular one. This is a pre-op checklist. Do they have their ID band on? Or have they been NPO? Did they get the pre-op teaching? Is informed consent signed? History and physical attached? Do they have any allergies? Are there lab results here? Pregnancy, bleeding times, and all that good stuff. EKG, chest x-ray, right? If they needed one. Are they clean? Were they showered? Were they bathed? Do they have a hospital gown on? Any specific preparations? Have they been completed? Do they have TEDs, anti-embolism stockings on? We remove jewelry. Now, oftentimes wedding bands, engagement rings, oftentimes they can't. They'll say, I can't get my wedding ring off. What we can do is take medical tape and tape around that jewelry. That's acceptable, but no other jewelry should be on. Valuables, which they shouldn't have brought, but they do sometimes. What did we do with them? A wallet, credit cards, cash money, those kinds of things. Dentures, prostheses, hearing aids, glasses, contact lenses. None of those things can go in. So where are they? What did we do with them? And every facility has its own, protocols as far as those are concerned. They shouldn't have on wigs or hairpins or, makeup or acrylic nails. And if they have acrylic nails, we got to take one of them off for the pulse ox. Have they voided? Or maybe we had to put a Foley in. We'll see. What are their vital signs? Did they have pre-op meds ordered and were they given? Did we get an IV in them? Do we have any old documentation that needs to go to the OR with them, like an old medical chart or x-rays that are previous that can be compared to the most current, right? Any of that stuff. Is their family there or next of kin? And is the client ready to go to surgery? And then you go, yes or no, and you sign off on that. That's the pre-op checklist. Okay. And there, of course, are different versions, but this is the basic information that is in every single one of them. Okay. Then they get transferred to the holding area. This poor little lady's waiting for surgery. Looks like she's talking to her anesthesiologist and the OR nurse, maybe. And what happens in the holding area? Well, make sure that the patient's the right patient. That's important. And are we doing the right procedure? Here's a fun story. In Florida, there's a hospital called Tampa General, and they had a big lawsuit. You know why? Because a poor gentleman went in for an amputation of his right lower extremity, and they cut off his left. And so, long story short, of course, this poor guy had to go back in and have the right one removed. So now he had no legs. So now, since that happened, and sometimes it takes something awful to happen to begin a protocol. If a patient is having anything amputated or repaired, an arm, a shoulder, an elbow, a leg, a foot, anything, both the patient and the surgeon with a Sharpie, indelible ink that won't come off, have to mark and initial. So for example, if you're having your right foot amputated, you and the surgeon both have to write on that foot, yep, this is the one. And on the other one, no, not the one. I know it sounds crazy, but that's what has to be done, right? What time is the patient going? When was the IV inserted? What size is the IV? Where is the IV? We're going to give them their prophylactic antibiotic at this point, if there's one order. And the OR is cold. I will tell you this, operating rooms are kept very cold. Reason being that, pathogens like bacteria and viruses don't do as well in very cold environments. And so it's a sanitary or hygienic measure to keep them as cold as they are. And older folks are cold anyway. And so we can sometimes, they have blanket warmers. We'll give them a warm blanket to get them warmed up before we bring them in to the surgical suite, which is what it's called. There's the surgical suite, right? It does not look like the suite at Resorts Casino, okay? But it's a surgical suite. It's very bright. It's very cold. It's anesthesiologist. There's lots of machines, blah, blah, blah. So it can be, a little intimidating to people. Usually by the time they're leaving pre-op and going into the operating suite, the anesthesiologist has done his or her thing, and they'll say, all right, start counting back from 10. And the patient will go 10, 9. And that's when they'll get them in there. They'll be asleep. They'll get the endotracheal tube in and get them hooked up to all the machines and get started with the procedure. Okay. We will explain to patients what to expect. Again, fear of the unknown. Most of this stuff is going to happen after the anesthesia, like I just said, because it's just easier. The patient has less fear, they're asleep, and then we put the tubes in, maybe put the Foley in, all that good stuff that needs to be done, okay? Nurses can be scrub nurses, they can be circulating nurses. So those are the nurses that work in the OR, that the scrub nurse and the circulating nurse are the two main nurses in there that are assisting with obtaining the sterile instruments, keep making sure the sterile field remains sterile, assisting the surgeon. The surgeon will say, hemostats, forceps, gauze, or whatever he or she needs, and that nurse will hand over the things to the surgeon. It's always great if you can to watch a surgical procedure. It's always, fun. First surgery I ever saw was a laparoscopic cholecystectomy, and this is a true story. And it was back in the early 1990s, so it was a long time ago. So I rode my dinosaur to the hospital. No, I'm kidding. Anyway, it was a very, very large woman who was having her gallbladder removed laparoscopically. And as we watched, we could see that the surgeon was kind of having a hard time. And at one point, the surgeon literally put his foot up on the table and was pulling, and finally did get this poor woman's gallbladder, and with it a gallstone that was like the biggest one I've ever seen in my entire career. Very pretty, lots of colors on it and stuff, but that poor woman probably felt like a truck hit her after that procedure. All right, we're going to talk about anesthesia next. I'm going to take a little quick break though, and I'll be back in a sec. We're back. All right, let's get back to where we left off. Share my screen again, and let's continue. Okay, so with anesthesia, we have two choices. There's general anesthesia and there's local anesthesia. General anesthesia, you're going to go to sleep, right? And when you wake up, it'll all be over. You don't have sensation, so you don't feel anything, loss of consciousness, the reflexes don't respond. Typically, it's IV. There are inhalation types of medications, nitrous oxide. Typically, oral surgeons and dentists will use that to put people to sleep, or just inhale the gas and go night-night, right? Endotracheal intubation, an ET tube. Once the patient is a little bit asleep and we get them into the OR, that's when we put the ET tube in. And I'm going to show you a picture of that. And that is a tube that goes down the throat and gets hooked up to the machinery for anesthesia. Anesthesiologist stays in the operating room suite the whole time and monitors the patient's vital signs, respirations, blood pressure, heart rate, pulse ox, all those things, and is controlling the anesthesia the whole time to be certain that the patient is in fact sedated, until that procedure is over. There are different types of opioids that are used for anesthesia. Propanol is a common one that's used for things like colonoscopies, right? That's was Michael Jackson's drug of choice. But yeah, lots of different medications, but they're opioid based. And so complications that can happen, I will add this in, even though it's not on this PowerPoint, but I'm going to add it in. Sometimes, not often, but sometimes, after the procedure is done and the anesthesiologist stops delivering the anesthesia, the patient doesn't just wake up. It's rare that it happens. So you will always find naloxone, Narcan, which is an opioid antagonist, in PACU and in the surgical suite. They always have that on hand in case they need to administer it to block the effects of the opioids and get the patient roused and woken up. And then there's something called malignant hyperthermia. And we're going to talk a little bit about that in a moment. The word malignant, people usually associate that with cancer. They say if it's cancerous, it's a malignancy. But malignant, the word means can cause fatal harm. Just like the word benign means harmless, but in relationship to cancer, we'll say a tumor is either malignant or benign. It's either cancerous or it's not. But those words have other meanings as well. So malignant meaning can cause fatal harm. Hyper, elevated thermia, temperature. It's a very bad fever, but it's a little more than that. And that's one of the potential complications with general anesthesia. Then we have local anesthesia. So local anesthesia, you're not asleep. So what we're doing is we are actually just addressing one part of the body, and we are just numbing it to the point where there is no sensation. Think about an epidural, right? Anybody that's had an epidural, maybe with delivery of a child or with a cesarean section, right? It numbs you kind of from the waist down. So you have no feeling. You're awake, but you don't have any sensation. Okay? So that's a local anesthetic. Okay. There is a picture of an ET tube. And so the tube goes down the throat, as you can see the shape of it. And the cuff down here gets inflated with a syringe of air. There's a tube here that's the syringe gets attached to inflate the cuff to keep that ET tube in place during the procedure. Okay. So when the patient wakes up, they'll sometimes, oh, I got a sore throat. That's why. Malignant hyperthermia. It is a hereditary muscular disease, and it's can be triggered by general anesthesia agents. Okay. It can be fatal. If they start to develop it, surgery has to be stopped. Anesthesia has to be stopped. They need 100% oxygen given immediately, and we have to get their temperature down. We will even give them iced IV solutions to get their temperature down, because we're talking about body temperatures of 106, 107, right? We need to get their body temperature down. And then dantrolene sodium, which is a muscle relaxer, is given immediately IV to relax all the muscles. What happens is all the muscles start to become almost spastic, and that it's almost like the muscles are working and jacking up that body temperature. And it's hereditary. Like I said, it is rare. It's not common, but it is something that you might need to know about. And so there you are. Okay. With spinal anesthesias like epidurals, right? You can see here some examples. And so the anesthesiologist places a needle in between the vertebrae of the spine into the epidural space, or into the area that's around the spinal cord. And injection that is an anesthetic goes in there, and that numbs everything from whatever level. So if you look at A, right, you can see that it's going in. This is lumbar 2, lumbar 3, right? So it's going in between. This one's going even lower. This is going in between lumbar 4 and lumbar 5, right? And so depending on where it is placed, the nerves that emanate from in between these vertebrae from the spinal cord, they are the body parts that will be numbed, okay? And then there are other adjunct agents. Adjunct agents, things like what I talked about earlier, maybe some benzodiazepine to, you know, keep people a little sedate before the actual anesthesia. And then there are things that are procedural sedation. We used to call it conscious sedation. There's a med called Versed that was given where the patient is sedated, but it's almost like, it used to be called a twilight sleep. So the patient is, it's like a dream. They're kind of conscious, but kind of not. And any memory they have is more like a dream than anything else, right? So scopolamine used to be used for that, and we called it a twilight sleep. Here's another picture of surgery. They're all in the surgical suite, working very difficultly. This is the anesthesiologist. The anesthesiologist is always seated with general anesthesia at the head of the bed, right? And so, you know, he or she is making sure that the vital signs are stable and anesthesia is slow and steady, so the patient is kept sedated during the whole procedure. And this is a picture of PACU. That is a very old PACU, but PACU nonetheless. Just a little representation of what's there. You know, the patient will still continue to be monitored, EKG, respiratory rate, vital signs, etc. PACU nursing diagnoses, you know, there's a risk for aspiration. Like I said, we want to make sure the gag reflex becomes intact again, et cetera, et cetera. You can take a look at those. Family visitation, you know, the family has a right to be informed. But, you know, in this day and age, there's typically one family spokesperson, whoever the next of kin is. If the patient has a medical power of attorney, healthcare surrogate, that's the one you talk to. If they do not, the next of kin. Well, what does next of kin mean? If the patient is married, legally, their next of kin is their spouse. If the spouse is dead or the patient is not married, the next of kin would be either the patient's mother or father, or patient's sister or brother, or patient's adult child. Okay, that's a next of kin. So if the patient hasn't designated a healthcare surrogate, then the next of kin is the one that we speak to, and it depends on the marital status and so on and so forth. Okay. In order for a patient to be able to leave PACU, their vital signs have got to be stable. Their O2 and SAO subscript 2 means SpO2, right? Must be greater than 90%. They have to be awake. So in other words, if I say, hey, Mrs. Jones, hi, right? The respirations cannot be depressed. In other words, they have to have a respiratory rate that's within normal limits, 12 to 20. And if there was any bleeding, the bleeding needs to be controlled. So we would never discharge from PACU actively bleed, right? And then safety. So the bed should always be in the lowest position, side rails up. 2, not 4, because 4 is a restraint. 2 is safety. Call button must be within the patient's reach. You must always make sure they understand. Don't try to move without help, especially with the first ambulation, okay? Because you're going to have them change position slowly, okay? They're going to go from supine to sitting, and they're going to sit on the side of the bed, dangling their legs for a few moments before we have them stand. And it's always best practice to do a blood pressure supine, and then a blood pressure when seated, and then another blood pressure when they do rise, to make sure they're not suffering from any orthostasis. So we're looking for a precipitous blood pressure drop with change of position. And in order for it to really be considered orthostasis, we're looking for 10 millimeters of mercury or more. You know, with systolic, diastolic, there needs to be a drop. And then they would be symptomatic. They would feel dizzy or lightheaded, right? And there you go. That's good nurse taking her time with poor old Mrs. Jones. That's a groovy looking gown she's got on there too, isn't it, huh? Yeah, that's an old picture. Look at the phone at the bedside. Everybody see the phone? That's what it looked like when I started nursing. Anyway, all right, nursing diagnoses for post-op patients, right? Pain, there's risk for infection, breathing pattern, airway clearance, peripheral tissue perfusion. So are they going to be able to heal? Urinary retention, side effect of opioids, you know, impaired skin integrity, which they have if they had just had surgery, not risk for, they actually have impaired skin integrity. Imbalanced nutrition, because they've been MPO, and can we start them on something? Constipation, opioids, impaired physical mobility. There's a lot. There is a picture of a stapled incision, okay? And I gotta tell you, that's a sloppy job. It's a sloppy job. Doesn't look good, right? But you know, not everybody is an artist when it comes to surgery. And what you're seeing with B, these two little puncture wounds, there was probably a drain in there, surgical drain, like a Jackson Pratt possibly, or something that was allowing drainage of fluid. And then here you've got a surgical incision that's stapled. And as you can see, there are a couple areas here that don't look great. This looks like it's a little dehisced. You're missing a couple staples. There's some erythema, which is expected, but the areas here that are opening, see this one, and then this one over here, I would be a little concerned about that. We would be monitoring that because that increases their risk for infection and non-healing. And when we talk about healing, we have phases of healing, and it depends on what kind of wound the patient has. So when we look at A, an incisional site is optimum for healing because it's a clean, straight incision, okay? And what should happen is that the doctor, the surgeon, should suture it, and then as it heals, there's gonna be a little scarring there, but it should heal up nicely. If the patient should have a wound that dehisces, right, opens up, that will present them with a large kind of irregularly shaped wound. That wound cannot be closed on the outside because it needs to heal from the inside out. So what you're looking for is granulated tissue. The inside or the wound bed should be beefy, red. It should look like you just cut open a piece of prime rib, right? That means it's healing. And then eventually it's going to close from the inside out, and they're going to have kind of a bigger scar. And then we have the worst case scenario, a wound that has opened and become infected, and that we need to resolve the infection. So we're going to have to keep that wound open, like with packing, iodoform packing, until we resolve the infection. And then as the infection resolves and it starts to heal, you know, what will happen is then they will suture it up later. Can't suture it up until this is healed, the infection is resolved, and it's starting to heal from the inside up. And then we can suture it. They're going to have a wider scar, you know, than the guy with the clean, straight incision that just healed up nicely. So primary, secondary, tertiary. There you go. There are your healing phases. You got primary, secondary, and tertiary. Okay. There is the difference between a dehiscence and an evisceration. A dehiscence means that a stapled or surgically sutured or even crazy glued surgical wound opens up. That is a dehiscence. And evisceration is where part of an internal organ comes out of that open incision, okay? Here, and this is most common with abdominal surgeries, part of their intestines coming out. Whatever do you do if you walk into Mrs. Jones's room and you look and you see her intestines hanging out of an open surgical incision on her abdomen? You want to get them in a low Fowler position with their knees flexed, and you want to cover that wound with sterile dressings, or at least as clean as you can, that are moistened with normal saline, okay? You got to keep it wet. You got to call the surgeon immediately, monitor their vital signs to make sure they're not, you know, losing blood or whatever, they're not in shock, IV fluids, and they're getting right back into surgery to put their intestines back and close that incision back up, okay? These are board questions. So you find an evisceration, primary action by the nurse, low Fowler, knees flexed. Second, cover that wound with sterile dressings or clean towels, moistened with, it says here, warm. You may not have time to warm up the normal saline, but get those soaked towels or dressings over that evisceration, okay? And then ambulatory surgery discharge criteria. Their vital signs have to be stable. They can't be bleeding. They can't be puking. Their pain has to be under control. They have to have voided. They can't be, you know, displaying signs of orthostasis. In other words, no dizziness when they're upright. And there has to be a responsible adult to get them. And then, of course, teaching. And you need to give this to them in writing and orally. What do they have to do about wound care? What medications do they need? What are the signs of complications? What should they call about? What do they not need to call about? How long must they rest? Should they drive, operate machinery? When do they follow up with their surgeon? And you have to make sure that the patient signs that they understood, and they usually don't, and they're going to read it again and probably call you later. And then any prescriptions that are necessary for the patient. Okay, there we are, discharge teaching. Love her glasses. This is definitely a picture from the 90s. And then inpatient, right, discharge instruction. So if the patient is an inpatient and now they're being discharged, it's basically the same thing, right? Do they have any wound care they need to be responsible for? Or are we going to send a home care nurse or PT or OT? What medications, complications should they call about? Follow-up visit, et cetera, et cetera. What do we need home health for? Well, home health can send an RN, an LPN, speech pathologist, PT, OT, and even an aide. The registered nurse is there for assessment and complex nursing care and teaching. So, what kind of follow-up do we need for this patient to make sure that from the time we discharge them to home and the 2 weeks that they have to wait before they see their surgeon again, do they stay stable, safe? LPN will reinforce that teaching, help with wound care. And then speech therapist, well, they do speech therapy if necessary, swallowing evaluation and treating. PT is for ambulation transfers. When you think PT, think lower body. When you think OT, think upper body. That's an easy way to remember it because OT, occupational therapy, is about things like bathing, dressing, cooking, eating, right? Are they able to do those things? And then your unlicensed assistive personnel can help with things like ADLs and IADLs while they're getting OT and PT, right? And then we have some review questions that I'm not going to go through, but how about that for perioperative nursing? All right, well, I'm going to stop my share and you guys know where to find me for questions. And that's all for today. See ya. And remember, you can even see my tattoo here. Life is chaos. Okay.